Hello, my name is Jorge Cortez. I'm the director of the Georgia Cancer Center at Augusta University in Augusta, Georgia. We're going to be talking today about some AML treatment challenges and something that we're calling who, when, and how. These are my disclosures. The treatment of AML has not improved much, and part of that was because some of what we were doing was just changing the doses of cytarabine, and this is a good example on these randomized comparing 3+7 versus higher doses or intermediate doses of cytarabine, and you can see that the outcome is identical no matter how you use the doses of cytarabine. So that didn't work well in this context. In the salvage setting, we also had a number of drugs that were investigated, and you see a few examples here. As you can see, the overall survival in all these cases was really not different at all compared to the standard of care. So really, we had not made much progress in many, many years. So what we call the path of cure in the 1970s was what you see on this slide. And then by the 2000, we really had changed very little. We changed the percent of blast, we changed, adding the cytogenetics and the type of classification, but the management did not change. Until very recently, where we now have the molecular profile, we make the assessment according to fitness. We do hypomethylating agents for some patients. We do MRD assessment and a few other things that we have intervened. And we'll see what that means in a minute. But in terms of the AML landscape, again, in the 1970s, we divided patients by age, and there was arbitrary cutoffs, usually around 60 or 65. In the more recent years, we did it by fitness, which perhaps is more accurate, but it's sometimes very difficult to calculate. Now, very recently, we've had a number of drugs that have been approved in AML. And this is a summary of all these drugs that have been approved in the last 3 years or so. And I'm highlighting some important elements. I'm not going to go into detail of all of these. One important aspect here is that some of the ones that are directed at specific mutations, more important, the FLT3 or the IDH mutations, are supposed to be done by the FDA-approved test. But of course, that's something that's not always available, and we base it on what we have available in our own laboratories or in referral laboratories. One of the drugs that's important to mention is this drug called CPX-351. This drug is a liposomal formulation of cytarabine and daunorubicin that maintains a 5-to-1 molar ratio that seems to be optimal for leukemia killing. The pivotal study included specifically patients aged 60 to 75 with secondary AML, either treatment-related or secondary from MDS. And the results I'll show in a minute, but this is just showing you the in vitro data demonstrating that persistence of that 5-to-1 ratio that preferentially gets the drugs into the leukemic blast compared to the normal cells, and that results in an improved survival in animal models compared to the free drugs as we had been using them up until now. Now, as I told you, the pivotal study, the primary endpoint was overall survival, and as you can see on the right panel here, that was met with a significant benefit, median survival 9.5 versus 5.9 with standard 3+7. Again, this is secondary AML, and this was associated also with an improvement in the response rate with a CR or CR plus CRI. Perhaps more attractive is the issue of these molecular abnormalities that we see in many patients that have transformed not only our ability to prognosticate, but also helping us develop some new specifically targeted agents for specific subsets of patients. One important question is, but if I have to wait for these molecular abnormalities, my patient is going to do worse. Well, this study from Germany addressed precisely that, saying, well, what is the impact of waiting 5 days, for example, for the results of the molecular test? And as you can see here, it does not affect negatively the outcome. So the benefit of waiting for those results clearly outweighs any loss any time lost. Now, when we're talking about older patients, what are our concerns when we're talking about giving older patients a standard chemotherapy? Well, we worry about the myelosuppression because they are more susceptible to infections, they can get sicker. We also worry about organ toxicity, whether it's going to damage more their kidneys, their heart, etc. These patients usually take many other medications, so could there be drug-drug interactions? Hospitalizations, if patients need to be in the hospital more, they actually do have a worse prognosis, and many do not want to spend too much time in the hospital. And finally, what are the patient's goals? What are they looking for, to have a better quality of life or just to live longer? And so if we look at an individual like the one that we see here, I mean, this is an individual that looks older, he looks like he's suffering, he looks tired. So how are we going to manage a patient like this? Of course, if you look at the whole picture, this gentleman looks tired because he's finishing the Toronto Marathon in less than 4 hours. So the question is this an individual that we would consider fit or unfit? So these definitions are not always as clear-cut as they appear to be. Well, regardless of how we define fitness, let me talk about some of the drugs that have been approved for these patients that are unfit for standard chemotherapy. And Venetoclax is a very important one. As we all know, a BCL2 inhibitor approved for lymphoid malignancies. But here I'm going to talk about it for the treatment of acute myeloid leukemia. Very importantly, on the single-agent study for refractory or relapsed acute myeloid leukemia, the response rate was not very impressive. Only about 19% of patients had either a CR or a CRI. So nothing to really be very proud of here. But when we started combining it with hypomethylating agents, you see here that the response rate is 67%, which already starts standing out as a very high response rate for patients with, these are older patients, they're treatment naive, but we don't see these kind of responses with any other therapy. That is also associated with an overall survival with a median of about 17 months, which is much more than you would expect in this patient population. And you see some of these responses are fairly durable. So these drugs, these combinations started becoming very attractive and eventually was approved for this patient population. Now, I want to highlight this study that was just recently presented at EHA, which is a randomized study, which is a confirmatory study for ASA Venetoclax versus ASA versus placebo. And you can see here that any of the endpoints, response rate, event-free survival, transfusion independence, overall survival, they're all significantly better than azacitidine versus placebo, confirming what we already suspected from those high response rates in the single-arm study, that these would be much better than we can expect with azacitidine. You also have combinations of Venetoclax plus low-dose cytarabine, and again, on a phase 1, phase 2 study, it showed very impressive responses. You see here a response rate in the range of 60 to 70% in different subsets of patient populations. But then this randomized study that was recently published of low-dose cytarabine plus minus Venetoclax, you see a trend for better response rates, but unfortunately, the primary endpoint, which was overall survival, was not met. Now, you see there is a difference in favor of Venetoclax plus low-dose RC. It just did not meet statistical significance. So that is the reason why it was considered a negative study. But there is a positive trend in all of the endpoints. There have been studies looking at more intensive decitabine, 10 days, for example, plus Venetoclax. And I'm particularly focusing on the refractory relapsed AML and MDS or on patients with secondary AML who have been previously treated. You see here that 13% of patients had received prior hypomethylating agents. And you see that there is a response rate in about 50%. Now, these are refractory relapse patients or secondary AML, so that's why it looks a little bit lower. These are more difficult patients to treat. And yet, a very reasonable response rate. However, there is about a 20% probability of mortality in these high-risk populations. So that is important because these combinations can be very myelosuppressed. Now, the combination of venetoclax plus low-dose RC has been analyzed in terms of the different molecular abnormalities that a patient may have, and you can see some patients can have particularly good outcome. NPM1 mutated patients, in particular, have a good outcome. Curiously, the patients that have co-mutation with IDH1 or 2 doesn't seem to be quite as good. And the same thing can be said in patients on that the cytarabine plus venetoclax that I showed you earlier. Certainly, RUNX1 mutation don't do as well. P53 mutation patients don't do as well. That's still a very difficult patient population to manage. And then you can see the outcome of these patients depending on the subsequent therapy. If they receive subsequent therapy, they have a better outcome. Some patients just went to hospice or something like that. That's a no. The other treatment modality that was recently approved for patients not eligible for standard chemotherapy frontline is Glasdegib. Glasdegib, as you know, is a hedgehog inhibitor, smoothen inhibitor, a pathway that's very important in embryonal development, but also prevalent, important for the leukemic stem cell. There was a randomized phase 2 study of cytarabine plus minus Glasdegib in these older patient population that had also other features of unfitness, like high creatinine or severe cardiac disease. And you can see here that the overall response rate is significantly better with the combination, 23% versus 5%. And that extends regardless of the cytogenetic abnormalities. But most importantly, the overall survival, the primary endpoint, was significantly better for the patients with the combination, and that led to the approval of this combination. Importantly, the benefit in survival is seen even in patients that do not achieve a complete remission. So that's an interesting observation, and the reason for that is not clear, but it partly explains why the survival benefit is so large, even when the response rate is not as high as we've seen with the other combinations. We've also analyzed what's called the Q-twist, meaning how much time is spent in toxicity versus in relapse, and then how much time is spent without any toxicity or relapse. That's a valuable time, the twist time. And in this analysis, you can see here that most of the benefit comes from that time, the time spent without toxicity or relapse, 5.8 versus 2.4 with the low-dose cytarabine. So it is valuable time for these patients that comes from the combination. Now, I mentioned 3 different combinations, venetoclax plus low-dose cytarabine, venetoclax plus hypomethylating agents, and Glasdegib plus low-dose cytarabine. So if you look at them side to side here, at the bottom, you see the responses and the overall survival, and you see there is some variability. Perhaps the best in this group looks with the venetoclax plus hypomethylating agents, but the patient populations are not the same. For example, in these studies, there were more of the older patients in the venetoclax low-dose cytarabine, and particularly in the Glasdegib plus low-dose cytarabine. There were more patients with secondary AML in the low-dose RC combinations, and that usually comes because the patient that already took a hypomethylating agent from MDS did not get another hypomethylating agent. So rather than drawing firm conclusions here, I think one can say that these are 3 valuable options for this patient population that of patients who are unfit for chemotherapy. And this is a collage of the different survival curves that have been presented from different studies, both from the azacitidine and the cytarabine, when they were approved as initial therapy compared to standard of care, and moving to the right for these combinations with venetoclax or Glasdegib plus either cytarabine or azacitidine, which have improved survival against the control and now have become the standard of care for these patient populations. I want to mention another drug, the gemtuzumab azithromycin. As you know, this drug was approved many years ago, but then taken away from the market because of some negative randomized study from SWOG. But recently, it came back to be approved based on this randomized study called the ALPHA study, where patients at age 50 to 70 with newly diagnosed AML were randomized to receive standard chemotherapy alone or in combination with gemtuzumab. And the results showed an improvement in overall survival and an event-free survival in favor of the combination strategy, which led again to the approval or reapproval of gemtuzumab or zogomycin. You can see here that nearly all of the subsets of patients benefited from the combination, except perhaps of the patients that have adverse cytogenetic features. Although if you look at the adverse classification group by NCCN or ELN criteria, there is still a trend in favor of those patients that received gemtuzumab. So today, I would say that in the treatment landscape, that as we defined it earlier, we have not just one group, but we have the CD33 patients can receive gemtuzumab. Then you have the FLT3 mutated patients can receive FLT3 mutation, FLT3 inhibitors. The secondary AML patients can receive CPX. The IDH mutations can receive IDH1 or IDH2 inhibitors. And the unfit patient population can receive Glasdegib or Venetoclax in combination with either hypomethylating agents or low-dose cytarabine. And of course, there's a lot of overlap between these groups. So the treatment is becoming much more complex, but it's also becoming much more effective and beneficial for these patients. And from this analysis on a study that was published in the New England Journal of Medicine a few years ago, I want to direct your attention to the left, where you can see that the contribution of the genetic abnormalities and cytogenetics and all these things is important, but a good part of the outcome of the patient is derived by the treatment, the demographics, and other clinical variables, including this nuisance, which includes whether the patient is included on a clinical trial or not. So all of these features together determine how well a patient is going to do once we do the diagnosis of acute myeloid leukemia. But very importantly, that has to come with assessment of the molecular profile of each patient. So this is how I would put it all together. Certainly patients with FLT3 mutated AML, you have FLT3 ITDs, FLT3 inhibitors. For secondary AML, you have CPX351. For the IDH, you have IDH inhibitors, etc. And then you can see, depending on the fitness and the unfitness. For the unfit patients, the decision between Venetoclax and Glasdegib, I think Venetoclax is much more myelosuppressive. So if you have worries about the myelosuppression, Glasdegib is a very good option. If not, Venetoclax plus hypomethylating agent may be very valuable for that patient. Of course, some of this is just my opinion, my experience, and it'll be important to test all of these things prospectively in clinical trials. So I'll stop here and I thank you for your attention.